Today, we are going to break down AA gradient, aDO₂. This concept is essential for both exams and real clinical care, yet it's one of the most commonly misunderstood topics in respiratory physiology. Many students memorize numbers or disease risks, but when I talk to residents, that memorized knowledge often collapses the moment they face an actual patient. So today, I'll explain the AA gradient using a simple schematic I always use when teaching residents, a clear, intuitive way to understand why hypoxia happens and which mechanism is responsible. Let's turn this into knowledge you can recall instantly and apply confidently in their clinical practice. Let's start with normal physiology. Imagine that air contains 100 units of oxygen enters the airways. It travels down the trachea, divided into right and left bronchi, and finally reaches alveoli. Of course, we have hundreds of millions of alveoli, but for simplicity, let's illustrate this with 4 alveoli. If 100 units of oxygen enters the lung, they divide it into 50 and 50, and each alveoli receives 25 units. Blood flow enters with hemoglobin. The tract that carry oxygen and each alveoli receives 25 units. Blood flow enters with hemoglobin, so each alveolus gets 25 and take up 25. For alveoli, the total 100 units transferred into the bloodstream. In this perfectly idealized model, alveolar oxygen equal 100, arterial oxygen equal 100. So a gradient equal 0. Actually, real lungs are not perfectly uniform. Actually, ventilation tends to go more to the upper lung zone, like this. Example 27, 26, 24, and 23. And perfusion goes more to the lower zone, like 23, 24, 26, and 27. So in this case, 27 is the alveoli, but finally gets 23. And next one is 24. And next one is 24. And the last one is 23. This natural physiological mismatch results in uneven uptake, often totaling around 94 units giving. So AA gradient equal 100 minus 94 means 6 remains. This is why aDO₂ under 10 is considered normal. Okay, next, let's look at diffusion impairment. Each alveolus still receive 25 of oxygen. I'm using ideal model in this case to make it simple, and blood flow can carry 25, but because of the alveolar membrane is thickened or structure abnormal, oxygen transfer becomes inefficient. Instead of taking up 25 units, this alveoli taking up 23 units and 20 and 21, adding up 89 units, giving a gradient equal 100 minus 89 equal 11. This is a diffusion impairment. And here's a crucial characteristic. Diffusion impairment worsens significantly during exercise because blood flow faster, leaving less time of oxygen to diffuse. A classic ILD, interstitial lung disease. Okay, next let's moving into VQ mismatch disorders. First one is atelectasis. Oxygen distributes into the remaining open alveoli. The atelectasis is caused by collapsed alveolus. So oxygen distributes into the remaining opening alveoli about 33 units each. The collapsed alveolus receive blood, but no air, so 0 oxygen unit uptake. If the other takes up 25 each, total 75, means AA gradient equal 100 minus 75. So AA gradient is 25. PE looks same, but actually different. Alveoli receive normal oxygen, but perfusion is absent in blocked region. So uptake 0. So total uptake becomes 75. So AA is 25. This is classic dead space physiology. Next, COPD. Destruction of alveolar walls lead to enlarged alveoli. Some receives excessive ventilation, for example, 40 units. So others are 20, 20, 20 because of the enlarged alveoli. But perfusion is limited even in enlarged alveoli. So uptake is kept 25 and others are all 20. Even though their perfusion can deliver 25 units. Totals may reach 85, yielding a gradient of 15. COPD is a representative VQ mismatch disorder. This is an area where people often get confused, so I'd like to pause for a moment and clarify the terminology by referring back to the schematic we just reviewed. We organize the definition of VQ mismatch, shunt, and dead space. VQ mismatch refers broadly to any imbalance between ventilation and perfusion. In the sense, atelectasis could technically be considered a form of weak mismatch, because ventilation in the region becomes zero. However, when blood continues to flow into the alveolus, where no gas exchange can occur, we give this situation a special term, shunt. In other words, when ventilation is completely absent, V equals 0, we classify it as a shunt. A shunt refers to the mixing of blood that has not been oxygenized with blood that has been oxygenized in other alveoli. Now we turn to the opposite scenario where perfusion is absent, Q equals 0, like this. The resulting condition is called dead space or wasted ventilation. So also shunt and dead space can, in a broad sense, be placed under the umbrella of weak mismatch, like COPD. We typically distinguish them as separate entities because their underlying physiology and clinical implications differ significantly, especially in the point of oxygen response. In the case of classic weak mismatch, total O2 uptake increases smoothly. For example, we use 20 units O2. This turns 25, 25, 45, 25. So it changed to 25. So totally 100. Of course, AA gradient is 0. But atelectasis and PE, it's difficult to improve with oxygen. This is one of the most practical bedside distinctions. Alright, that's it for today. I hope this helped clarify an area that often feels confusing. This is a knowledge to stay calm and act first. See you again in the next lesson.